I've had a really long and interesting career. I have seen huge changes. If you think, when I went to medical school, there were no CT scanners, there were no MRI images, there were no ultrasound machines. So we already have the beginnings of that revolution in our ability to image the patient. When I was a resident in radiation oncology, we were still in New Zealand using cobalt machines. We were still doing our treatment planning pretty much with paper and a slide rule. And so if you allow me to start from that position, as I look at my career, we have seen tremendous change. We've learned to adapt, we've learned to modify, and we're now learning again how to use the technologies that we have to the best advantage. There's one story, I don't think it's apocryphal, that EMI produced the first first CT scanner. And their marketing people went out and did a whole pile of surveys, and they came up with the view that there would be a world market for CT scanners of 6 units a year. We're now beginning to understand the difference also between the image as, if you like, a picture, and the image as a biomarker. And so I think that we're on the forefront of an amazing change in our ability now to use those technologies. I think with the introduction of the PET CT scanner, and more importantly the PET MRI scanner, we're going to begin to use the image as a biomarker. So can we stratify patients for treatment? Can we predict treatment response? Can we actually use the image in a much more sophisticated way in treatment planning to ensure that our gross tumor volume is accurate? I think Gino Falone and his LINAC MR is going to give us the ability to track changes in the real functional volume of the tumor to ensure that that component of what we are doing. I think it's interesting that we're now seeing increasing papers in the literature looking at ultrasound as a therapeutic technology as well as a diagnostic technology. So the changes have been night and day. I think we're now beginning to learn that we've got a lot to learn about how to use the technologies we've developed. But at the end of the day, the patient has benefited, whether we're using it as a diagnostic tool, as a predictive tool, or as a treatment planning tool. There's no doubt that the care now is far better than it was 200 years ago when I was training. So if I look at the elements of MRT practice, I'm struck by 3 things, I think. First, compassion. If you don't have compassion, if you don't display compassion in every waking moment that you're working, you're being less helpful to the patients than you can be. I think the second is what I would say is clinical acumen. We must never get to the stage in any of our jobs where what we are doing is simply a routine box-ticking exercise. We have to understand why we are doing what we are doing. So whether it is as a therapist, or as a nuclear medicine tech, or as an MR tech, we have to understand the science and the biology behind what we are doing, what that scan is, what that treatment plan is. What are the risks associated with not doing it as well as we can? And the final piece is just that real element of, I can't think of a better word than professionalism, that everything we do is focused on the end goal, which is the care of the patient. And everything flows, I think, from those 3 things. To be collaborative, it really involves meaning that everybody in the team has a voice. Everybody in the team has a role that is more than a narrow prescribed role. The role is to use their clinical skills, to use their clinical acumen, to use their technological skills and knowledge to ensure that the patient is getting the best care. And that best care is not only the quality of the image or the quality of the treatment plan or the quality of the interpretation. It's the overall care they get whilst they are in the department. It's the overall care they get when they are just talking to people, when they're just chatting with the technologists. We've got to remember a lot of what we do must make people and their patients and their families very nervous. We're going to irradiate you, we're going to inject you with a radioactive pharmaceutical. We have to ensure that that element of compassion that I mentioned earlier is in everything we do. And as you build these collaborative teams, we have to allow the MRT to grow in not only knowledge, but in responsibility and in autonomy. And I'll remind you that in Europe, in Australia, it is common now to have consultant radiographers. So consultant MRTs who really are operating at the same equivalent level within the system as the consultant physician or the consultant physiotherapist. We've got to understand how that works, what that means for care, what that means for practice, but most importantly, what that means for team building and for letting people grow through their careers. So you've asked me how important it is that we give to the public's safe and ethical and competent care. I would include the word compassion in that they receive compassionate care and that they receive timely care. Those are a continuum. Ethics underlying everything that we do. I believe that we owe it to our patients that each of us is practicing within the team to the best of our abilities, to the limits of our competence, and in a system and in a structure which ensures that the patient gets the right treatment at the right time, in the right environment. Those have to be the fundamental underpinnings of healthcare. They have to be the fundamental guiding principles of everything we do. So whether it's a technologist or a physical therapist or a physician or a nurse, it applies to all parts of the profession. It applies to all of the caring practitioners. If we don't achieve that, then we're failing our patients. We're failing their families. Medical practice, clinical practice, in the second quarter of the 21st century must build much more on those teams. It must build much more on that constellation of ethics to compassion if we're actually going to make the service we offer as good as it can be and as good as it should be. Leadership is actually building a vision for an entity, be it a healthcare organization, a hospital, a department, a grouping within a department. Communicating that vision, finding the resources to enable that vision to be achieved, and ensuring that when it's achieved again to the best that we can do it. I see huge opportunities for leadership in everything we do. People who can build a vision, whether it's a small vision on improving care, improving workflow, to what the system should look like in 10 years' time, or bringing in new technologies, bringing in new opportunities. Remember that Canada really has 11 different healthcare systems. We don't have a single national system. And if you look at the international league tables, we're middling in outcomes. I think we can do a lot to improve what we do, and I think we can do a lot to improve how we actually deliver the care at the sharp end. One of the fortunate things about the disciplines that we work in is that technology continues to grow and to advance and to improve. We continue to see improvements in imaging technologies, in radiation therapy delivery, in radiopharmaceutical development. I think that as we go forward, we're probably going to see one of those sharp jumps in the impact of those technologies on clinical practice. I think in the first instance, the idea of the image as a biomarker is going to become important. Whether it is a diagnostic biomarker or a therapeutic biomarker or even a theranostic, I think the image is going to become a lot more important in helping manage care. I obviously speak from my own area of interest, which is cancer, but I think we've seen it already in cardiology, and with some of the Alzheimer's imaging compounds, we're going to probably see it in neurology and dementia care as well. So I think the first thing we're going to see is the image intersposing after just the diagnosis of the disease, but helping in treatment planning, helping in predicting outcome, perhaps most importantly in stratifying patients for treatment. We now know that the biology of a cancer, for example, is as important, if not more important, than where the cancer started. And so many of the novel biological therapies targeting a specific signaling pathway may be found in a percentage of patients with lung cancer and gastrointestinal cancer. We're targeting a pathway. We know that we can begin to image some of those pathways. Hypoxia is one that we can look at. So I think we will see that the use of image becomes more sophisticated. Secondly, the image in radiation therapy planning is clearly now the most important tool that we have. And one of the things I'm very proud of is how we've been able to integrate a great deal of teaching in cross-sectional anatomy and three-dimensional imaging into the new course that we developed at the University of Alberta. I think that is truly going to prepare therapists for practice in the second and third halves of the 21st century. That ties in with an understanding of the biology of the disease that we are looking at, imaging, treating, helping to provide information to the referring physician on. So I think that's going to be a really important area. But I do think that we have to look at how we can incorporate artificial imaging into what we do, how we can incorporate radiomics into what we do. So using population health techniques to improve what we do in the imaging clinic, in the radiotherapy clinic, I think is a huge opportunity for us. And as that applies to medical radiation technologists, I see huge opportunities arising. My view is that the most important thing that we can now offer the profession from the University of Alberta is a master's degree leading to advanced practice, ultimately a PhD leading to a consultant technologist status. I think the technologist community is a huge untapped resource for medicine. And I think those are many of the people who will be bringing skills in coding, skills in artificial intelligence, skills in using image display formats to significantly enhance what we can offer our patients. And I think a lot of that clinical research can come from the technologist community. It's happening in the UK, it's happening in Europe, it's happening in Australia. I see no reason why it can't happen in Canada. And I think importantly, again, it goes back to this idea of giving people the skills to grow in the job that they have, the autonomy to use those skills for maximum benefit to the patient and to the system. I look forward in 10 years' time to seeing what that advanced practice idea looks for. I hope it's grasped by both the administration and by the technologist community, because the benefits could be huge.